Hi, I'm Sonali Tamhankar. I am a senior clinical data scientist at Fred Hutchinson Cancer Center. This is an exciting time to be working in the field of natural language processing. The tools that we have available today as NLP developers are incredibly powerful and nothing short of magical. Over my years working as a data scientist in the field of healthcare, I have come to realize that it may behoove us to be like water in bringing the enormous power of these tools to the magnificent, complex, and somewhat rigid landscape of healthcare systems. Adaptability is key. Today, I'll illustrate my point through three projects. These will range from the simplest natural language processing projects to the more sophisticated ones built on state of the art technology. Let's start with the simplest. So, this project aims to enrich structured data sources through NLP on unstructured data. So in healthcare, our organization uses Epic, for example, and there will be some fields like the lab values that will come in as structured data fields in the data mart. But then there is other information that is buried in clinical notes. Cancer, I work at a cancer center, which we can think of as a single condition when referring to someone having cancer, but in fact, it is more than 100 different diseases. So there are different types of cancer. For example, in breast cancer, there is a patient can be ER, PR, or HER2 positive or negative. There are different receptors. And the type of cancer has implications for treatment and prognosis. And this information, what type of cancer a patient has, this is not available as a discrete data field at our organization. So this project was to extract patient level information from clinical notes to understand our patient panel for better resource planning and care delivery. So this is a quality improvement project. And all we did here was just simple regex string matching, right? So the approach was to break up clinical notes into sentences, just count total sentences that match the string we wanted. So for example, ER can be either estrogen receptor positive, or it can be just a plus sign there. There are different ways in which clinicians might refer to this status. So we looked for those strings, but also excluded where the condition referred to was for a family member and not the patient themselves. So this was the simple approach. There are advantages to even this simple approach. It is simple to program. It can be improved incrementally. We can tweak these things. This is deterministic and fully explainable. We can refer to the exact notes because of which a patient is characterized a certain way or not. We validated using information on 37 patients against clinically abstracted notes. And we found this simple algorithm to be pretty accurate. It was 90+% accurate in all cases. And this was sufficient for our use case because what we wanted to do was to look at panel level information. We wanted to know what is the age distribution of our triple negative patients. So triple negative is where the patient's ER, PR, and HER2 type is negative, and there is special interest in clinical criteria for triple negative patients because they are harder to treat. Some of the treatment modalities depend on the fact that patient is ER positive or PR positive, so on. Other use cases are to balance provider load. There are other projects that we can kind of tie in with this data. For example, looking at disparities in emergency room visits for breast cancer patients. Are they related to different cancer types? So even though we are just doing like a drop of work, there are ripple effects downstream. So we can start with simple projects like that. This next project I want to talk about is an operational project. So this was in the context of healthcare regulation. We all know this is very, very complex. This information comes from the American Hospital Association. There are any number of regulatory requirements, and it does take a lot of work and a lot of money to make sure that hospitals are compliant with these regulations. So this project was to support our regulatory compliance team. The idea was to identify relevant references from multiple sources. Now, this was a nice project to start with for me to start exploring some of the state-of-the-art tools, because this did not involve any PHI. All the information that is available is in the public domain, right? So our regulatory team picked some documents for us. So this was handpicked. For example, the CMS State Operations Manual Appendix A, this is like some 500 plus pages document. There are state laws. We are based in Seattle, Washington, so state laws apply. There are a lot of other documents that they wanted us to look through. So the idea is to do a semantic search through these documents to answer questions like, how should expired medications be handled? Right. So when the user asks a question like this, the tool will look through all these documents, doing a semantic search, and find excerpts, find relevant excerpts. And at the same time, it can find medications from this manual, as well as there are rules about disposing drug samples. It will find those. So that was the use case here. Under the hood, of course, I'm using retrieval augmented generation. So we take all these documents and we chunk them up, we split them up and store them into a vector store. When a question comes in, relevant chunks are pulled from this vector store using cosine matching, and these relevant context is provided along with the query to the LLM to get the final answer. In my case, I did not even use the final answer. Just getting the chunks in itself was meaningful, because the emphasis here was getting precise and accurate information rather than getting an answer that is, like one answer, but maybe somewhat wrong. There may be hallucinations there. So we did not want that. So I just stopped at getting the matching excerpts. So as I said, these documents were in the public domain, so we didn't have to worry about protecting PHI here. I used Fierce and LangChain with these embeddings and hosted this tool on Hugging Face. And building on these use cases, then we moved on to combining generative AI and traditional machine learning methods. So this project was for our sickle cell providers. The goal there was to reduce avoidable emergency visits for sickle cell patients. I believe as data scientists, we can make an impact through our choice of problems that we choose to work on. Research funding, for example, for sickle cell is below the level of other diseases, even though it affects more people. Majority of sickle cell patients are Black, and there are sometimes socioeconomic factors that interplay with the clinical factors that affect these patients. So you must have seen, or you may have seen this illustration that talks about inequality, equality, equity, and justice. So this was one of my motivations for working on this project. Sickle cell patients tend to have painful episodes. They're called sickle cell pain crisis. So I'm not a clinician, but my understanding is that there is a genetic reason why these patients, red blood cells, they have this different shape called sickle shape. And especially when the blood is deoxygenated, these cells get kind of sticky, and they can clog blood supply. They can stop blood supply to important organs, and that can cause a painful crisis. And that is part of the reason why patients will, that is one very important reason why patients will end up in the emergency room. Some of these are unavoidable, but some of the pain crisis could potentially be avoidable. Up to a third of these emergency room visits are potentially preventable. There are medications that can be given to patients upstream that can potentially impact their quality of life and reduce the pain crisis. So the goal here was to create a tool that might help our providers in designing interventions for our patients. So we had questions like which patients are at highest risk, and how can we empower providers to understand the drivers of this risk and design effective interventions to reduce these ED visits. So in this project, I combined the traditional machine learning techniques along with the generative AI methods. uh, the data came from Epic Clarity. We had I defined a cutoff date and used features for 1 year before the cutoff date. I used demographic information, clinical information like medications and labs, operational information like reasons for visit, encounters, past emergency room visits, and so on. Uh, the idea was to try to predict ED visit in 1 month after this cutoff date. So for this project, I used random forest. We had 136 patients. 23 of them had an ED visits within a month. So this was an unbalanced class. We used medications, lab values, reason for visit. For each one of them, I created a column. So for example, reason, visit, name, pain management is a column. The row would be one for each patient, and the number that will go in there is the number of visits that patient had for pain management in the 1 year before the cutoff date. So I created a column for each one of these conditions, and we removed the infrequent values that left us with about 372 columns. I kept the top 50 columns, did a 10 test split, and just this simple method gave me an area under the ROC curve AUC to be 0.85, which was actually pretty good. So there is room to tweak things here. So there are things that we can maybe add other columns, add other features, experiment more with the model, but we were fairly satisfied with this AUC to begin with. What we also wanted to understand was that, okay, you have a model, so we are able to predict risk, we are able to pull, say, patients with the highest risk, but what do you do with it, right? How do you make this actionable? So there is overwhelming amount of information available to physicians. So how can we actually help them act on the information that we are giving them? And one tool I wanted to use was Shapley values. The core idea is this allows one to understand the drivers behind risk. So if the cohort risk is here and a particular patient's risk is here, what are the factors, which are the features that are causing this difference between the average cohort risk and one particular patient's risk? So the Shapley values kind of assign this difference to different features, and one person may be at higher risk of emergency room visits, say because of socioeconomic factors. Another patient may be at higher risk because of particular lab values. And knowing this makes the whole tool much more actionable for providers. The other piece I wanted to use was also the information that's in the unstructured data. And this is where the new tools that we now have at our fingertips with generative AI methods come in handy. So we can have the physicians, we can give them the ability to interact directly with the clinical notes through natural language querying, which is the kind of tool that we built here. So here is the concept for the tool. We started with the highest risk MRNs. MRNs is medical record numbers for a patient. So we start with that list, and then the provider can go and ask information for one particular MRN or one particular patient. Once that MRN is entered here, then some more information for that patient will be pulled up. There will be like maybe ED visit dates for the past few months. There can be the Shapley values plot, like the patient's risk and what are the risk factors. So there's some things that explains this patient's risk. And then there is a place to chat against patient notes. So this is the piece that uses the methods like generative AI. Llama 2 is what I use on the back end. And I built this web interface on Streamlit. So this is a screenshot from the tool that we built. The tool, of course, has to be password protected. It was hosted within the organizational firewall. And in fact, right now, we have kind of put a pause on this work while we are developing generative AI policy. So these screenshots are a little bit older from before. After validating credentials, a list of highest risk patients will be pulled. So this is of course fake data. One can enter a specific patient MRN here, and then some information about that patient will be pulled up. I'm also pulling pain scores here. Now, pain score is a somewhat potentially defective measure because this is simply the answer to question on a scale of 1 to 10, what is your pain right now? We have seen that the pain score numbers can vary a lot. But there is some information in just knowing whether the question was even asked. Then this piece is the Shapley values. So here, this is reason, visit, name, no show. So as I explained before, this is the number of visits that the patient had that were marked as no show. So the patient did not show up for the visit. So this means that for this particular patient, they had 6 such visits, whereas the cohort mean was 0.82. And this is one of the drivers. So one can see how much are different features contributing to the patient risk. And once a provider sees this, once they kind of interact with this tool a little bit, they might have questions that they want to dig deeper into. And this is where one can converse against the clinical notes. So the provider can enter a question here, and the tool will then pull up the answers from the clinical notes. So in this case, I'm also displaying the answer. We are kind of experimenting with that piece. I want to stick to the excerpts as much as possible, because this is there's no room for hallucinations in excerpts, right? Like I'm just giving the direct source information. So this makes things much more transparent for the provider. So the provider can ask a question like, why did this patient miss appointments, and how many appointments did they miss? And then the tool, behind the scenes, this tool works pretty much exactly the same as the previous example where we experimented without the PHI. This one we do have PHI, so this was structured differently, but the technology is the same. We are using retrieval augmented generation behind the scenes. Now, instead of the different documents that were provided by our regulatory compliance team, now the documents I'm using are the patient notes. And the metadata for those is the patient MRN and the visit date, so that I can pull that information. And that way, the provider can also go and look at the full text. I am providing also another tab here. So once the provider notes a date, like if this information sounds relevant, they can go to the next tab and just enter the date. And this can then pull the full information, the full clinical note. They can also go to the EHR itself to get the full note, but I just wanted to put all of this in one place. So this was our experiment with the sickle cell tool, building the sickle cell tool for providers, combining the traditional machine learning approaches using the random forest model and the Shapley values, along with the further deeper inquiry into clinical notes. The model that I built itself was based on structured data, but then through this conversation, the provider can also dig into the unstructured data and get further information, making hopefully the tool more actionable. So that is my message today. Be like water. This ecosystem is very complex, but there are unique opportunities for work, and keep making the difference that you make every day through your work. So thank you very much to our organizers, presenters, and participants. I look forward to questions. Thank you.